Hello and welcome to our webinar on gender and transforming health systems, which is the final webinar in the THET Health Partnerships webinar series. You should be able to see our screen. You're all currently on mute, so we're not able to hear you. The recording of the session along with the slides will be available after today on our website and YouTube channel in case you have any problems with connectivity or in seeing the slides. We'll have some time for questions at the end, but in the meantime, if you'd like us to know of any problems with the audio, please let us know through the typed question box. We will try to address the problem. So my name is Lucy, and I'm the Assistant Grants Management Officer here at THET, and I'm joined by my colleague Susan, who is the Quality and Learning Manager also at THET. We're here to introduce today's topic and presenters, and to hopefully ensure that the technical side of things runs smoothly. So just a quick run through of the agenda for today's webinar. I'm going to hand over to Susan for that.
Hello, good morning, and thank you so much for joining us for this, which is the last in the series of webinars on the subject of gender and health. We have invited one project to be sharing their specific experience of how they addressed gender in their project in Uganda, led by Professor Callie Tan with her team of Fiona Beckledge and Rachel Lastman. And we also have Fokokura Theopista, I hope I've pronounced that correctly, who was working as a consultant on another project. She's a lecturer at Cavendish University in Uganda, and she will be giving us a context of gender and health in Uganda. So perhaps we can kick off with a slight overview of gender and health and where we are at the moment at the more theoretical level. We now know that health and healthcare is not gender neutral. At all different levels, gender and sex, so the cultural defining of men and women, as well as the biological, have significant impact on both their health and access and use of healthcare. In the workforce, women are far more likely to be the frontline workers, the first person that someone will see as a community health worker, a nurse, or a midwife. But as you go through the health system, you're more likely to be met by men. And it's interesting how, whilst the majority of women will be seen by midwives with, if in sexual and reproductive health terms, it's obstetricians and gynecologists will almost always tend to be male. In terms of the health-seeking behaviour, men and women use services, take up services very differently. Whilst women might be more likely to visit a health facility, it is more often than not because of their sexual and reproductive health role as opposed to their overall health role. And their access to or use of healthcare can be very dependent on the men in their family. Many will need to seek a man's permission to use a service and will not have the financial resources to undertake long-term treatment because of problems of access to transport. And ironically, the area that is always considered of women's health, of sexual and reproductive health, it is more likely to be the man who makes the decision on contraceptive use within the household, both in terms of spacing children or whether or not to avoid a pregnancy at all. Men are far less likely to visit health facilities than men. Again, often because of cultural attitudes, but also because of lack of access during working hours. The final area of diagnosis and treatment of women is also found to be different. And a seminal study in 2001 that was looking particularly at pain identified that women are more likely to be given sedatives to treat pain, whereas men will be given pain medication, because they have been diagnosed as women having more psychological reasons behind the manifestation of pain than men. This is a problem not only in terms of gender equity, but also in terms of treatment. It is denying women the respect of being able to identify their own symptoms. And medication is also affected by the fact that so few women have been involved in many clinical trials, or clinical trials have not taken an account in the past of the different ways that medicines affect men and women. And the fact that women have smaller organs, for instance, more likely to have a higher proportion of body fat, and of course have very different hormones, all affects the way that medicine affects their bodies. Gender equity has been recognised and is being seen as an issue which needs to be understood at the international level. However, the concepts of gender equity still need to be better understood, particularly in healthcare settings. It needs to be broadened from looking at what are considered women's issues to accepting that men and women have exactly the same potential risks of a lot of health-related issues, for instance, non-communicable diseases. But the attention being paid to the way that gender affects disease in the body and the way that you will take up a health service is still in its infancy. And one of the problems of that is that a lot of the international organizations believe they are already gender sensitive and do not see how to make their programs more gender transformative. And the space for women, particularly women from low and middle income countries, to share their experiences at the three levels, their experience with the health workforce, in the way that they take up services and in diagnosis and treatment of them, is still very, very limited. In FET last year, we undertook a study which tried to look at the way that gender was being implemented in the programs that we were funding or had funded over the previous 7 years, to try to understand the way that gender was being taken up within our health partnerships. And it was following the recommendations of an evaluation undertaken in 2015, where it was saying that gender had been rarely considered by either of the health partners, the UK-based or the partner in the LMIC, and that very often gender-related issues were coincidentally included rather than specifically included as well, and situation analyses very rarely used a gender lens. This was despite the fact that, as the statistics on the screen show, more women than men are involved in the scheme. That more women are giving more time from the UK side into the scheme. So the study specifically looked at project that we were running in Uganda and Tanzania, and tried to spend as much time as they could working with the healthcare workers at facility level rather than at hospital level, and at the user of health facility services. So patients, but also those in the community that might in the future need health services. And the results were that, as that quote says, patriarchy is alive and well. Men are more likely to be promoted and listened to. And that both men and women believed that a lot more could be done to improve the gender-sensitive behaviour of staff in the health facilities in Uganda and Tanzania. Though interestingly, most of them did feel that they were already quite gender-sensitive. One particularly telling quote was that female doctors are usually discriminated by patients as well as fellow staff, which demonstrated that the attitude towards men and women of the local community will be critical to the way that healthcare workers are respected and listened within the health system itself. And that discrimination at the societal level has a significant impact on the way that women can develop and fulfill their career ambitions and their personal potential. The statistics found that 66% of women said they preferred to see a male doctor, compared to 31% of men, though this may fall into the trap of right answer syndrome, where men will have told us what they would expect us to hear. But within the clinical staff as well, there was bias. That both men and women believed that the stereotypes of men being doctors and women being the support caring staff was alive and well. Women felt that men do not take women in power seriously, and that men will not follow policies that have been developed by women or follow directives from higher up at the district or provincial level and apply them in their health care setting, and that still women speaking up should be chased from the community. The second area that we looked at was stereotyping, where, as you can see, there was a strong belief that men are better doctors than women, because they think of them as more efficient and professional, and that the sciences are too hard for women. And the final area that we looked at was imbalance, gender imbalance within health worker and the healthcare setting, where there was an assumption and an expectation of unequal opportunities for men and women that was verified by the fact that in our statistics we saw that less than half of the doctors that were trained were women, and anecdotally that the majority of administrative and managerial staff in senior positions are male. And these are some quotes again that were from that study, that there are more men than women in top offices, and women are often given the inferior job. And that discrimination here of a senior surgeon who would not allow female intern doctors to support him through surgery, limits the opportunities for women to advance in that healthcare setting. So these were the main findings that we had of the survey that we undertook. On the basis of this, we decided to hold this webinar and to invite inputs. So first will be Theo, who is giving us an overview of gender and health in Uganda, followed by Callie and Fiona, who I think are with us. So thank you very much, and over to you, Theo. That one, yes. Have you unmuted her? Yeah, I know. Yeah. Hello, Theo. You're now live.
Thank you. Good afternoon, everyone. This is Theopista Fokora from Uganda, and I work as a monitoring and evaluation consultant in a project of resilience in obstetric skills that is based in Masaka and Chitovu Hospital in collaboration with Masaka Medical Hospital that is facilitated by the Euro College of Obstetrics and Gynecology Uganda. And at the same time, I work at Cavendish University Uganda and Uganda Matters University as a lecturer. So I'd like to please kindly, let's have another slide, please. Yeah, thank you. So my simple task is to discuss the take of gender in Uganda. And so to begin with, we say that the Universal Declaration of Human Rights set out among its fundamental rights to set equal rights of both men and women, because as the previous presenter said, it's quite important that we understand this baseline information so that we can get to know what it takes to make sure that we give equal rights to both women and women. And this must be achieved through education and health. This must be achieved through education and health. So I am going to first discuss about health and then education. So next slide. Yeah. So we find out that in Uganda, the level of education of women is a barrier to both entering a higher level of healthcare structure and of course taking up health services. So the baseline would be to first have a very good background of the quality education, so that after the quality education, you could get these potential women to come into a very good top managerial position in a health sector. But you find out that 10% of women have no education compared to 4% of men. And so that means out of every 100 females in Uganda, 10 of them do not have education at all compared to 4 of the men. And so in conclusion, we say that 68% of women are literate compared to 77% of men. And it takes us to a lower advantage of grabbing opportunities for top managerial positions in especially the health sector. So another slide, please. Yes, so we say after that background of lower education, especially for women, we find that 5 in every 10 males are given labor employment, and compared to the 4 in every 10 among the women. So that means that even in employment sector, we find that males are given employment more than females. So it is to the disadvantage of women. And therefore, we find that there are more women engaged in self-employment. This includes business and so small-scale business and industrial activities, so that they get some little bit of income, though they do not get enough income to take care of their own families. But also then we find that out of the 7.3 households that are in the country, many of the households, more or less 30% of the households are headed by women. And you find that they are not educated, they are not employed in any form of jobs that they do, but they have to take care of busy families. And this is too much. 1.8 million families are headed by women compared to 5.5 million households that are manned by men. So it's to our take that we need to understand the background of men, of women, and the roles of women in families in order to take them at a higher level, to make sure that we include them on both education and of course the resultant factor will be health, because health is a component of both physical, social, and psychological well-being, not merely the presence of disease. So if we find that women are not catered for both in education and well-being and rights to their education, then even their health is questionable. The rendering of health and acquisition of health and demanding for quality health services will be determined by their education and by their levels of employment. So it's very important to know that. Let me have another slide, please. Yes, so we find that this slide specifically talks about political management positions in Uganda. It is very important to note that 32% of women given the chance to participate at least in one planning meeting at a village level, compared to 44% of men, as reported by the Uganda Bureau of Statistics 2016, page 78. So we find out that more women are left out even at the planning level at a village, at what we call a health center one, or at a village level. So if they are left out from the grassroots, it becomes very hard for them to be encouraged to join the top management team when it comes to those levels of management. And then you find out that recently in the 10th Parliament, which actually began for Uganda in 2015, we find that 92% of all those that are in Parliament are men, compared to only 8%, which is quite a minute number, not even a representation of women in the Parliament. Though it has increased, but it is not what it's. And so we find that even to the cabinet ministers, 36% of the cabinet ministers and 30% of the we have 36% of men as cabinet ministers, as compared to 30% of state ministers as women. So women are always given the lower priority, are always given the next priority compared to the men. And they are going to see the reasons as to why, or the challenges that we have identified for the limitations to women taking up these low upper levels of management. Though, however, we find that the Ministry of Health has appointed Dr. Jane Acheng as the Minister of Health, and Dr. Atwine as the Permanent Secretary for Health. Then we find that there is limited proportion of women that have been represented in the health sector. And so we need to understand in detail the reason as to why women do not absorb, do not be assimilated in the health sector, especially at the top levels of management. And so another slide, please. So we are looking at the barriers to women in positions of leadership in the healthcare setting in Uganda. Ladies and gentlemen, allow me to present there is lack of leadership skills, and these skills are supposed to be taught by especially the home makeup. We are supposed to help these women to have leadership skills even when they are still young. But these leadership skills lack, because we are going to see what culture talks about the leadership skills, that a man is supposed to be the one to lead this, the man is supposed to take care of big positions, of big tasks, and so we lack skills for women. We also have what we call gender bias. In the previous what Louis presented, he mentions about the female doctors are usually discriminated by patients and even the fellow staffs. It is quite true in Uganda that female doctors are always called nurses, and so it demotivates them at one point in time. So it's very important that we eliminate this gender bias by sensitizing the community and both the formal and the informal sector to understand that women have a very big capacity and a role to play in leadership and management. So we also have what we call lack of flexibility in working environments. As part of the gender roles, we find that women are not so flexible, maybe to move from one place to another, to move from this, because of the gender roles in the community. They have to pray, they have to be home, they have to take care of the home people, they have to, and they find that they are missing out on these leadership skills and leadership positions, especially at a higher level. So we also find out that we don't have mentoring that starts from a level of maybe a kindergarten or a nursery or a primary level, that a female must take that lead to be mentored from the beginning so that they can know what they are supposed to do in the future, and they can make that capacity to reach their top goals and their whatever they want to be in future. So we lack mentoring in Uganda. We don't have that mentoring. Though we have some counselors in primary schools and secondary schools, they also don't lead us to what we want to do in future. And so you find out that skills, especially for leadership, die meanwhile as you are moving into the later stages of our development. So we also have lack of career advancement opportunities. Women have their intrinsic behavior, because sometimes they are not used to challenging issues, to challenging situations, so they lack advancement. They miss out on advancement opportunities. They can't grab opportunities. Why? Because they think men are supposed to take off the big roles, the big tasks, the big opportunities. And of course, with top level management, you find that there are big tasks ahead of you: accountability, financing, human management, material resource management, and all that. So it becomes harder for females to have that, because they have no background motivation and no background care for that advancement opportunities. And of course, culture in Uganda, culture plays a very big role to modeling of adults, especially the females. Where we come from, different cultures have their different make on females. A female is not supposed to talk loud. A female is not supposed to express herself. A female is not supposed to talk twice when a man is talking. A female is supposed to always abide by the man's decisions. And so it gives females that inferiority character, and so it deters most women from gaining their positions. And in fact, most women who have gained top positions find that they have gone away with families, they have divorced, they have gone out of, so, and it becomes very hard. So you find that most of the women are becoming single mothers if they want to get to a top level of education and a top level of management. Then the other barrier would be social, family or spousal support. Men in Uganda do not love or do not wish or do not want the women to take up the bigger parts, the bigger positions in healthcare or in management. Why? Because they think if they would get lots of money, if they would get lots of knowledge, they would seem not submissive to their spouses. So it becomes a setback if a woman wants to have that emancipation of a top level aspiration. It becomes very hard for her to conquer with her husband. We also have the Queen Bee syndrome, which actually I explained when I was talking about culture. I explained the Queen Bee syndrome, whereby there is a queen. A queen is supposed to talk slowly. A queen is supposed to be humble, to move slowly, to not to even think of the future, but they think of her, they prep, they plan for her, they implement for her and everything. And so most of the women in Uganda have that Queen Bee syndrome. So they don't care as long as food is brought on table and it's not their own fault, as long as they're eating and drinking, and also that queen type of life. Then there is also the stereotype of life where men dominate culture, and which is actually negative. And this comes together with a family or spousal support, whereby even in culture, when you are married to a man and you're highly educated and you have a high management or high level position in the government or in the private sector, then to the family it clicks that you're not obeying to your husband, you're not taking care of the husband, you're not taking care of the family, and you just need to be down if you want to be culture in Uganda. And so we also have what we call work-life balance, which actually comes together with gender roles, because you find that top-level management issues need a lot of time to affect them. And so you find that women, as women, have gender roles which need someone to be at home and take care of those people that are at home. So it takes their time. And so we find that even if someone has a top-level management position, this barrier pulls the person down to affect it affects the quality and efficiency and safety of that. And so we have race discrimination. Thank you very much. The 4 minutes, I can see, so I'm going to be faster. We also have sexual harassment, actually, but also then we find out that in case someone wants to go for a top-level management, sexual harassment is one of the barriers. So to say that if you want to assume that top-level management, you must give in, because there are many men up, and if you want to get that job, then you must give in for the job, which is quite a barrier to that. So please, can I have the next slide? Thank you. Yes, the next slide. Yep. And so we also have barriers to uptake of quality health care for women in Uganda. Now, as I talked about education and those levels of management, we also have a team or a group of women that would love to have quality services, quality health services that can aid in increasing their life expectancy and, of course, the quality of life. But you find out that one of them is geographical accessibility. We have service location, which gives us a take on the distance between the households and the health facility. And so if the distance is quite long, then it is a deterring factor to accessing the quality health services. Then we also have households. Household location is one of them, because if you find that the geographical location of a household is maybe on a hilly ground or on a low ground, then it deters women from accessing these services. Remember, they are poor and they are in need, and they are disadvantaged and vulnerable at the same time. The availability of services, both health workers, drug and equipment. You are looking at the waiting time, you are looking at the wages that, of course, a quality service is always paid for in Uganda. Most have been analyzing the data that we've finished collecting about patient satisfaction in obstetric care services. I found out that even in public hospitals, in public health facilities, health workers are requesting for some bits of money to get to give services, to give quality services. Maybe they don't have equipment, maybe they don't have the drugs, they don't have what they can use. And so you find that's one of the reasons as to why we don't get quality of services are the wages that we cannot afford to give for the quality services. And so of course, also the information on healthcare choice is a problem. So for us in Uganda, we can get whatever we are on a pool side we get, but we don't have choice for the treatment. It is a small percentage of the women that have choice for treatment, especially those in top level management and those who have had their money to request for their quality. But most of the women in the villages do not have a choice to the information and quality of health. And so we also have the affordability, and affordability, of course, is in connection with the costs and the price of the service, and so acceptability. Yes, can we have the main slide? Yes, we can have the next slide. Yep. And so we also have action points. Actually, this is the last slide that I have with me here. So I tried to look at the action points that we can have. One of them is to formulate maybe written commitment to women's rights, and also to establish a women's right for health committee, which can help us sensitize the community about their rights to health. We also need to train this management and staff on women's rights so that they understand their rights, and of course undertake an internal organization assessment of the company policies, the Ugandan policies, and maybe the other policies that we can get from the rest of the countries, and see how they are taking it, and of course develop the action plan and implement, and also monitor and evaluate the quality of the services by looking at the quality assurance, and of course take action to improve the program. Thank you very much for listening. Thank you.
Thank you very much, Theo, for presenting and for giving us such an insight into some of the barriers that might face women in terms of their advancement through the in Uganda, and also some of the challenges that might affect the uptake of services of women in the community. So we will just move now, so thank you very much. We'll just move now to the third presentation. It's the, with Fiona and Callie. Though I think that Callie, you've been having some problems with audio. Let's hope that. Hello, is that Fiona?
Hi, yes. Hello.
Hello,
I'm also here with our. I'm just here with. We also have our project lead here in Uganda, Rachel Lassman.
Fantastic.
Hello.
I'm really pleased that you were able to join us as well, Rachel. Thank you so much. And Callie, are you also able to join us?
Hello, can you hear me?
Yes, I can. Fantastic. We weren't sure. Great. Thank you very much indeed for agreeing to share your experiences from Uganda, and also with such gorgeous photos of the children, their mothers. So the floor is over to you.
Yeah, of course it was.
Hi, I'm having some issues with the internet connection. I'm in the NHS today, and the internet is not fantastic, and I'm not seeing the slides at the moment. Are they up on the screen? Is it just my internet delay?
Yes. Try to. Can you get to her name and see if we can? Yeah, turn on.
Rachel and Fiona, are you seeing the slides?
Yeah, we can see them. So I guess we'll have to lead it and you'll add in some information.
I've got nothing coming up on here at all. It's just got the name of whoever is talking at the moment. I have them on my
Would it
phone.
be at your end? Would it be worth trying to phone in again onto the webinar link?
Well, I can hear you very clearly. I think it's the internet speed bringing through the images.
Oh,
Because
okay.
even in the previous talks, the slides were changing much more slowly than I think the rest of you are seeing, is the only thing. I mean, I have the slides in front of me and I can guess what slide is up and start talking, and maybe we could do it that way.
Let's give it a go.
Okay, so first slide, the title slide, Gender Transformation in Child Disability Programming, Experiences from Uganda. And I'm going to talk today about gender and transforming systems and our experiences specifically in Western Uganda in child disability programming. Next slide. Maybe someone can confirm to me when the next slide is up so I know what others are seeing.
Yeah, next slide.
Yeah, so.
Great. So in way of background, we have been working in global newborn health research since 2010. The work that I do is focused on perinatal brain injury, prevention, outcomes and interventions. And as part of that research, which really started in babies with birth asphyxia, so babies at very high risk of disability as a result, we had a program where we followed up children with birth asphyxia or neonatal encephalopathy, as we call it, and found that at 2 years, only 40% of the babies had disability-free survival. And of the survivors, by 2 years, a third had cerebral palsy or a global, sort of severe global developmental delay. And we did some qualitative work amongst the mothers of children with disability. And what was really, the impacts on families were really striking. The mothers were often withdrawn within the group. They sat separately. It was clearly highly stigmatizing. They talked about the huge social, emotional and financial impacts of having a child with disability. And these children were only 1 year of age. So this was very early on in their journey of having a child with disability. And there was a lot of superstition, a lot of belief that it was related to witchcraft or something that the mother had done during pregnancy, that it was her fault. And there was a lot of discrimination in the community with regard to it, or as they reported to us. And there was also a lack of services. So we were referring at Malago Hospital is where we did most of this work. We were referring to child disability services, which was a neurology clinic to manage seizures and physiotherapy, but there was very little in the way of support for families information sharing and improving knowledge in how to care for these children with very special needs. So we developed an early intervention program for an existing program for older children called Getting to Know Cerebral Palsy, and currently called the Abana Early Intervention Program. And we're currently running a trial of that in across 2 sites in central Uganda. And the aim of the program is to improve child and caregiver health and well-being. Most simply, and the most important outcome that we're interested in really is improving quality of life for families with a child with disability. Next slide. So when we thought about the caregiver experience, this is just some examples of what the mothers told us. Here's just some quotes. This is Nadia, one of our lovely children with cerebral palsy as a result of her perinatal or what happened to her around the time of birth. Lots of families reporting that the father leaves, particularly if it was the first child or a young mother. Even my husband abandoned us. He said that he did not give birth to such hopeless children. He does not support us. And we found that about half of the fathers leave the family unit with huge financial impacts on mothers and families. My neighbour told me that I delivered a ghost. I'd better take him to the lake and throw him in there. I refused. I want my baby. Very little support in community level, a lot of superstition about these children and about the reasons that they have disability. But also they talked about grief. You feel sorry for yourself and wonder why it had to be you. So lots and lots of experiences shared by mothers that we wanted to see if we could, develop a program that would support those mothers. Next slide. So the program that was developed is a modular program. It's a group program for families, caregivers and children. They come together for 10 modules, between 6 to 10 mothers usually, caregivers and children per group, and groups are facilitated by an expert mother or a combination of expert mothers and a therapist, where therapists are available. There are some core principles of the programme, and although when you look at the wheel it seems in a very medical model of positioning, play, learning to move, learning to feed, the programme facility works in a social model of care really. So we aim to promote inclusion and participation for children and their families, maximise child development, optimising health and quality of life, promoting empowerment of caregivers through information sharing and peer support, and I'm going to talk about that a bit later, understanding the child and family experience, addressing stigma, and promoting the human rights of children with disability. Next slide. So the programme was developed in Kampala, and we already have very, very close collaborative links with the Keininga Child Development Centre, KCDC, who have a very established and comprehensive child disability programme running in Western Uganda in Fort Portal. And we were keen to incorporate the early intervention programme into the fantastic work that they were already doing, because we felt that it was likely a valuable addition in family support. And we were fortunate enough to get some STEP funding to roll out the programme in Western Uganda, and we'd already had a small pilot grant from the Royal College of Paediatrics and Child Health, and so the focus of this project has been to scale up the early intervention programme across two additional neighbouring districts. And the programme aims to, is entitled Early Detection, Prevention and Intervention for Infants at High Risk of Developmental Disability. And there were 3 arms of the programme. Next slide, please. So the 3 arms were prevent, detect and support. We aim to strengthen neonatal care to support families in surviving and thriving for their newborns. We also aim to detect those babies with early disability early on and refer them across to our early intervention programme for supportive care and rehabilitation. As I say, we aim to scale it up across 2 additional districts of Western Uganda. It very much builds on the existing infrastructure of child development and disability services at KCDC. And we'd seen in a previous pilot study, both at Malago and also in Western Uganda, a 20 to 25% improvement in family impact quality of life pre and post the programme, between sort of the beginning and after. And there was this aspect of strengthening neonatal care and follow-up of high-risk infants. Next slide. So why is gender important in early child disability programming? Well, we found it a really, really key component of what we're doing. First and foremost, primary caregivers for children are usually women, and often secondary caregivers too are usually grandmothers or siblings, female siblings. As described, the impacts, the social, emotional, financial impacts on caregivers, largely women, are very high. But also the majority of healthcare workers that these women are interacting with and who are identifying and referring these children are also women. But it isn't all about women, because the fathers clearly play a very important role, and you've heard in the last presentation, but you know, fathers are very important in decision making in the home and also in financial support. And so fathers have a really important role in enabling women to care for their children. Next slide. So a cornerstone of the programme is to empower women and offer peer support. And women clearly describe the impact of that as being one of the most substantial things about the programme. The programme itself aims to empower women caregivers, or caregivers generally who are largely women, to care for their child with special needs. What we have done a raft of qualitative work actually across both the trial sites, but also in Fort Portal, collaboratively with the MRC social sciences team that are based in Entebbe. And women are reporting in focus group discussions and in-depth interviews, raised self-confidence after the programme, raised respect and self-respect, I think, improved knowledge was clearly reported, reducing self-stigma, and also this sort of powerful impact of peer support, a feeling that you're not alone. Mothers said, it gave me confidence and I got to know what happened to my child, and I appreciated the fact that I was not alone. And women really clearly report the strength of this in improving their quality of life, their own mental health and the well-being of their children. Next slide. I've talked previously about discrimination and exclusion being reported by families as really important. And we have found, one of the focuses of our programme is to improve participation and inclusion. Reports from families, the facilitators taught us what to tell others, so we know, and our husbands and mother-in-laws are the very people that should get to know about this condition, as they blame and abandon us, yet we are not the cause. Women felt very empowered by understanding that they were not the cause, that this wasn't a result of something that they had done, that this was often a result of something that had occurred around the time of birth with their baby. Another mother said, sharing information with others has reduced stigma, because when we share, others stop talking about us and thinking that we messed around, and that is why we ended up with such babies. And this has improved how we interact with others, and many people around us are aware. So people talk about the sort of community sensitisation occurring as a result of what they learn within the group. And I think the group has impact for women at both individual level, but also at community level. Next slide. A very, very key aspect for mothers is their ability to work, and many mothers are unable to return to work because of caring for this child. And it was a key aspect that came across in our early qualitative work. And a lot of it was about the fact that they were too frightened often to take their child out of the home or take their child with them anywhere, because it was so stigmatising, and because it can be quite difficult to move around with a child with disability. And this picture really shows, I think, really highlights a really lovely aspect of the programme around positioning, and how you don't have to leave your child flat on their back on the floor under a tree, that you can position them in a way where they can feel included and they can participate, and that you can continue with your work. A mother said, we were taught how to carry our children as we do in our normal work. This not only helped us continue our work as we took care of our children, but also helped us involve our children in daily activities. We used to think we could not work when you have such a child, and I think this is a really, really important and key aspect of empowering women in this situation. Next slide. This is Betty. Betty is one of the expert mothers that helped develop the programme, and the programme was very much developed from the ground up by teams working with children with disability in Africa, but also by mothers, expert mothers who have children with disability. And Betty's son, Jono, has cerebral palsy. The facilitators often gain similar, talk about similar positive aspects of the programme as the mothers, but I think they also get a sort of good standing in the community, that a leadership role, and are very important in community sensitisation. One of our expert mother programme facilitators said, I've shared my experiences, and through sharing, others have trusted me. They share with me their experiences, and this gave me hope my child will get better. The experiences and interaction with other mothers and their disabled children gives me confidence. I've been able to relate freely with others, and it has reduced my stigma. And I think women talk about reduction in self-stigma, and that self-stigma is one of the most challenging things for them. And I think they feel empowered when it comes to self-stigma as well as external discrimination. Role of the healthcare workers, sorry, next slide. The role of the healthcare workers is extremely important. And I think it would be good if Rachel and Fiona said a couple of words at the end regarding this, but they've done some fantastic work at KCDC in training healthcare workers in the region in identifying children with early disability and improving their understanding and knowledge about caring for those children. And I think we've seen a shift change in attitudes toward children with disability as a result of that. The challenges that we had identified and KCDC identified as an issue was that, one of the key things is that, the nurses and caregivers, healthcare workers are often female dominated profession, but the leadership is often male, and so there is clear gender roles within the hierarchy in facility and community-based care. They work under high pressure, healthcare workers, and the pressure of work and the numbers that they have to see mean that they had limited capacity to respond. But they have also described to us that their limited knowledge of disability meant that they were very restricted in the care provision that they felt that they were able to give, and as a result were quite dismissive of and turned children away from services. It's common for us to say this, for our mothers to hear, this service isn't for you, when it comes to things like malnutrition services. However, after training and mentorship, there was a real shift change in that. So healthcare workers reported improved knowledge empowerment through and are more able to provide and refer for services. And I think they're very much still part of the KCDC team now, or extended team. And I think that's been really powerful for our mothers in accessing care. A female healthcare worker said, "I never had hope in these children. I used to think they were already wasted children and I couldn't care much. But now I understand that they can improve, and I also give them others." Meaning, and we get referrals now, Rachel has said, from healthcare workers on buses with children with disability sat next to them. So even outside their working environment, they're identifying children and referring them. Next slide. The role of fathers is really, really key. They are very important decision makers in the family unit. They often, however, leave the family unit, and they leave early, often as soon as the child can be seen to be not developing normally. How do we engage fathers?
With you. Hello, Callie. Hello, Callie, can you hear us?
Hi, we're back now. We just lost, the power's just gone off in Uganda, so we lost internet and everything.
Oh, so that's Fiona?
This is Fiona, yeah. I know Callie was talking about, Fiona and Rachel could add some more stuff about healthcare workers, and then the power went off, so our internet went off and the laptop went off, so we're scrambling to get back on.
And we seem to have lost Callie, and we can't seem to unmute her.
Oh, okay, so
do you want to take over the presentation? Can you see us on screen that we're on the role of fathers?
We're on the role of fathers. So yes, I think if we repeat ourselves, whatever what Kelly said, I apologize.
We'll forgive you.
Thank you so much. So yeah, the role of the fathers within a Ugandan setting is extremely important. They are seen as the decision makers of the family, even when they don't have much engagement with their family, and if they've abandoned and left the family unit, they still do have some control over what's going on. So yeah, we find that a lot of our families that we work with are single mothers or single grandmothers, or they're very much a female carer without a male representative in their family. And that's been a real challenge, because all families will then say that they're unable to attend the group sessions, or even for therapy sessions when where there is a male in the household, because he won't give the mother any money for transport to get to the meetings or to get to the groups. And so that's a real challenge as well. So we do have a few good, really well engaged fathers that do bring their children for therapy. They are well engaged in the family, and we're trying to use them to set up sort of fathers support groups and keep them, sort of try and help engage them in supporting other fathers in their communities and trying to get them to understand better and really re-engage with their families. We have found that with children attending physiotherapy or therapy sessions and also attending the program, that some are re-engaging with their families again. They see to understand the reasons of a disability and accept them and accept their children and their families, which has been a really positive outcome. But yeah, it's something that we need to be sort of looking at in more detail of how we can engage the fathers and the role that they can play within this. We have, during this project, we've trained how many fathers as facilitators, Rachel?
5.
So we've trained 5 fathers who are well engaged to be the expert parents to facilitate the groups, which has been, it's had sort of mixed results, and I think we need to look into that a bit more because women, if you've got a group of women, having a male in that environment does change the whole process a little bit, and we need to look in a bit more detail about whether that has had a negative impact in the changing quality of life for the mothers that have attended. So that's something that we need to look at in the future. Next slide. So so I need to find where the slides are. So do you want to read this one then?
So as Fiona said, we're piloting fathers as program facilitators, and I think our gut feeling is it will have an impact on sort of community sensitization, but we are a positive impact on that. But we're slightly concerned as to how it will impact on the women's group, the dynamics within the group. So with our healthcare workers report a lot on the role of fathers, about sort of how mothers used to explain to us their domestic struggles and we couldn't do anything, but now we're able to bring them together with their partners and talk about the children's condition. This has helped to sensitise men about disabilities. Next slide.
Yeah. Okay. Next slide. Okay. So one of the programs that we've developed, partly, when we were talking about the struggle of women to have meaningful work with a child with a disability as well, is that we've partnered with a great program called Street Business School. And so it's trying to train women in business and entrepreneurial skills. So we've actually we have 2 of the mothers who went through the early intervention program in our pilot program. So 2 years ago, have been trained as Street Business School coaches. And they are now working with groups of mothers. So they're teaching these skills, which includes market analysis, savings and investment, bookkeeping. And we don't give any startup capital. The mothers are tasked with saving and starting their own small startup capital, which they're then trained how to build. So starting with something like $1, $1.50, and how you can build a business from that. So we're really excited that we've just completed our 2nd cohort, and so we've got 55 businesses started, which is fantastic. And the response is that these women are able to support themselves much better. They report, it's amazing the difference it has in terms of the self-confidence and their self-worth, because these are women that believe that they had no role in terms of business, had no way to make their own money, whereas now they feel that they're able to buy extra food and medication for their children, Certainly if a child, we have a lot of children who are suffering with malnutrition, and they're able to buy extra food to support that. They can also pay their own transport costs to get to the group sessions or to a therapy session, rather than relying on a male figure. Next slide. So yeah, go ahead then.
In summary, we found that gender plays a really important role in early childhood detection and intervention, and our programme is aiming to empower women to care for their children, to promote inclusion and to reduce self-stigma through peer support and mentorship. Our healthcare worker training and mentorship has helped change attitudes towards children with disability in our local area. And to summarise, in terms of the role of fathers, it's important and complex, and engaging them can be challenging.
And I think that's our last slide, isn't it?
Yes.
Yes.
Yeah. Yeah.
Yes.
Thank you very much indeed, and thank you for stepping in. I think we've lost Callie. Clearly, internet access within the NHS was a bit of a challenge. But thank you very much. And it was really interesting to hear how you were approaching the issue from a very holistic perspective, which obviously puts gender as critical within the whole picture, and sees the woman and her relationship with her child living with a disability in a broader context. So thank you very much. This is now time to have open for questions and comments and thoughts. Lucy, do you want to read out?
Yeah, so I think either if you send in your question on the chat, the sort of the group chat, or if you unmute yourselves and then read out your question, and then the speakers will all be unmuted so they can answer. So first question or sort of comment is, I think that men inclusion is essential and will empower women to care for their child and change in-laws' attitude, especially mothers-in-law. The support of men will lower women's stress. So does anyone have any sort of thoughts or comments on that?
I totally agree with the comment, and I think involving men is really important, and particularly around mother-in-laws. It's certainly something that our mothers verbalise an awful lot, is the impact of mother-in-laws and the stigma that they create.
I think men also have a much stronger role within the community, in terms of if we can engage men in understanding disability and being accepting of disability, they're much more likely to have a larger influence across their own communities, like the village chairman and other village leaders are much more likely to be engaged if it's a man that's supporting rather than a female.
Yeah, and we've got 2 outreaches that are in our area that were started almost entirely from 2 different fathers. So they mobilised children in their village, and they've turned into health centre based outreach over time. So I think getting the men involved definitely sort of is what changes the stigma and gets things moving on a community level.
But there's still so much blame being placed on the women rather than the men, and that's, there's a huge problem there.
Yeah.
Yeah. Okay. Oh, sorry. Theo.
Thank you very much. The last presentation was quite interesting, because for the case of Uganda, we find that men have a very big role to play in the development of a family, and of course education and health as a whole. And so we have carried out a research about how to support women women's savings and skills in marketing and saving generation. But we found out that in case you don't involve men in women's saving, then the women get challenges, especially when they are saving, and men want to take their money to enjoy it or because they need it for their own good. So I think it is quite important for the women, for the men involvement in these developmental issues, so that we can sustainably think of them working together and developing their family together and so developing the nation, which is quite a challenge in Uganda, especially to the low level people and the poor people, the vulnerable population. Thank you very much. And then I also wanted to ask those who have implemented the project, how has they found it? Has it been a challenge to sustainably save the money, especially for women compared to men or something like that? Because for us, we found a challenge when we want women to save and men have to get that money from them. So I don't know how they have overcome that challenge.
I think that's a comment for Fiona and Rachel.
Yep.
Sorry, I did start to respond to you and then realized that we were still muted. Yeah, I fully understand what you're saying. That yes, women make the money, whether it's through business, through running the we have that problem with the parents, the expert parents, that the mothers earn the money doing the group and then the fathers will just take the money. And it's something we need to be working alongside the families with the social workers and with other community members to try and redress the balance there. They will, and that's why we sort of say, in terms of the Street Business School, how to reinvest in the business rather than just saving, or they start in savings groups. We also are encouraging many of the families where possible to start a business together, so that they're able to support each other as they develop the business, and also then they know where the money's going together.
Thank you. Thank you.
This is Susan here. I had a question, I think to you, Theo, related to leadership and women being in leadership and the lack of women in higher positions, which may mean that some of the challenges faced by women are misunderstood within the system. And you say that in Uganda, both the Minister of Health and the Permanent Secretary of the Ministry are both women. Are they acting as role models in any way? Are they seeing their opportunity of improving understanding of health and access to health from a woman's perspective?
Yes, thank you very much for the question. As I noted earlier, I said that the Minister of Health, Dr. Jenna Cheng, and Dr. Diana Atune, the Permanent Secretary for Health, are women, and they have tried to strengthen the health system, of course, but because of their limited proportion, which is not proportional to the number of women, especially that are in Uganda, we find that there is a lot of knowledge gap. Many women do not know the roles, do not know how to take up those roles, and so it has not come out prominently from especially the top management to strengthen the lower or the middle level managers who are women, to aspire them to become top level managers and also to take their roles seriously. And that is a gap that I think is in Uganda, that we have to look up now to make sure that those top level managers need to motivate the lower level or the downer one, or they need to have a plan to bring women up take up those roles in the top management, which is quite a challenging issue actually in Uganda, because most of the people that are in management want to be there for quite a long time. And so mentoring of new cadre, of new people in an organization becomes very hard, because many people want to remain in jobs, want to remain in the comfort zone for a very long time. It becomes quite hard and challenging in that issue. Thank you.
Thank you very much.
Yeah.
Does anyone else have any comments that they would like to share, or thoughts, or have any questions? If not, I would just like to thank the presenters very much indeed for sharing their program and for sharing some of the background and some of the challenges faced in Uganda. For those that have been able to join us in this webinar, I hope you found it interesting and relevant. From this time, I think that this webinar is shared on our internet, the presentations, and
yeah, so it'll be on the website and the YouTube channel. So all the slides will be up, and there's a recording of it as well.
So I guess that we bring it to a close now, but thank you very much indeed, everybody.
Thank you.
Thank you very much.
Okay, bye.
Thank
Bye.
you. Bye.
Turn off.
What's that? We haven't time to talk to you.